I just again want to thank our second keynote speaker, Leora. That was fantastic. I'm sure that many of you will have questions during the fireside chat. So stick around after lunch if you have burning questions you didn't get a chance to address. So now we're going to have a panel discussion that talks about some of how this work looks like here at Michigan. So we are really honored to have our esteemed speakers on this panel to talk about a couple of really exciting programs. One is, and their experiences doing implementation research in these programs and pragmatic trials. The Michigan program on value enhancement, which is really this innovative way of scaling up and spreading innovations that are addressing high priority needs for the health system here. And the statewide Michigan collaborative quality initiatives, which are focused on building that learning health system to do more sustainable implementation work. So we're going to have, in the next couple minutes, we'll have our invited speakers come up here. We have Dr. Jeff Barnes, who's Associate Professor of Internal Medicine and Associate Chair for the Department of Internal Medicine at University of Michigan Medical School. We have Dr. Leslie Dossett, who is the Maudie Lane Research Professor of Cancer Quality Improvement, Professor of Surgery and Chief of Division of Surgical Oncology and Deputy Director for Clinical Innovation and Engagement for the Rogel Cancer Center at U of M Medical School. We have Dr. Michelle Moniz also joining us on the panel, who's Associate Professor of Obstetrics and Gynecology here at U of M Medical School, and Dr. Shawna Smith, who's Associate Professor in Health Management and Policy at the U of M School of Public Health. And our moderator for the panel is Dr. Devin Check, who's our Associate Professor of Learning Health Sciences at the U of M Med School. So we'll give them a couple minutes to convene up here, and they will be convening a panel to talk about their unique experiences conducting the implementation research in these opportunities here at Michigan Medicine. So thank you.
Great. We'll have each of our guest speakers here talk a little bit about their experiences with MPROVE and or the CQIs. Each person will speak for about 8 minutes or so, and then we'll have plenty of time for questions and discussion. So I think, can we go ahead and get started with Jeff? Are you able to start?
Sure.
Great.
So first off, thanks for having me, and it's great to see everyone here. This is a perfect opportunity for me because I sit on both sides of this piece. So along with Leslie, I co-direct the Michigan Program on Value Enhancement, which is this wonderful bridge entity that sits between the Institute for Healthcare Policy and Innovation, IHPI, and the health systems through the quality department, really thinking about how do we improve value in care delivery. So how do we think about right-sizing care, delivering care in the right space, often de-implementing care, making low-value care less often used. But in addition to that, I also co-direct one of the Blue Cross Blue Shield collaborative quality improvements, one focused specifically on anticoagulation care called the Michigan Anticoagulation Quality Improvement Initiative, or MAQI. For all of you, you know that all of these organizations pretty much have to start with an M because it's a Michigan. So, you know, you've got MAQI and Marquis and blah, blah, and on and on and on.
Can I just ask quickly, is everybody familiar with what the CQIs are? Yes, do we have some, feel free to raise your hand if we need a primer on sort of what the CQI are, because I know it is pretty unique for Michigan. Yeah. A little short explanation would be good.
So sure, I'm happy to give a brief one. So more than 2 decades ago, Blue Cross realized that there was an opportunity to think beyond institutions and to really think about how do you deliver high quality care sort of across the state. And that would be a win, not just for them, but for all of the people in the state. And so they asked us to come together to really collaborate and not be a my institution versus your institution, but really to say, how do we as healthcare professionals improve the quality of care delivery? So the very first one of these was focused on cardiac catheterization, so people who needed to have a stent placed in the heart, often because of a heart attack or because of chest pain. And how could we improve that care delivery? How can we avoid harms, things like that? Over the last 2.5 decades, I believe it has been, this has grown, and there's more than 20 of these now in all sorts of areas. Michelle runs one focused on OB, and so I know you'll be talking a lot about that. Many of them are around procedures, so, you know, cardiac surgery, neurosurgery, back surgery, OB surgery, things like that. But then others are more around healthcare delivery. So there's one focused on hospitalizations, there's one focused in the emergency department, and then the one I run focuses on anticoagulation care. And it's really about how do we bring data together and how do we bring people together to understand care delivery, to identify best practices that improve that healthcare outcome, and then to disseminate that across as many of the places in the state as possible. And then to use that as a model to demonstrate nationally and beyond how we can deliver high quality care. All of this is funded through Blue Cross through a number of different mechanisms, but really giving us the entity to own the data and to own the improvement process. So it's a really unique model that has been widely successful in several areas. But as I think about both what MProve is doing locally within our health system, and I think about what the CQIs are doing at a sort of statewide level, I see a lot of parallels there. I see a lot of opportunity to take data that we have collected, often more manually than we really should be, but that's something we're trying to improve on, to understand what that data is telling us, and then to try and improve process. And what I think has really been a push and something that we are continuing to work on, and I know personally we're continuing to work on a lot, is how do we move out of the sort of individual QI, I see a problem and I'm just going to try and solve it, into the more structured approaches of learning health systems and implementation science. And how do we bring that into the work that we're doing? And so whether we're doing that locally within MProve or whether we're doing that at a statewide level, we're trying to kind of move in that direction, recognizing that getting people in place, getting the resources, getting the engagement is often a little bit of a challenge. I think it might be better to have everyone maybe introduce and then do lots of Q&A before we get into specifics. So I might stop there and then
great.
Turn it over to others.
Great. I think that's actually a really nice lead into to Leslie's work, sort of bridging the MProve and CQI spaces. So Leslie, would you mind chatting a little bit about that?
Sure, and thanks again for the invitation to be here. So I think I'll tell a little bit of a short story about some work that we have done in the space of low-value preoperative testing and how we have gone from Michigan Medicine to the collaborative, back to Michigan Medicine, and to the collaborative. So I became co-director of MProve in 2019, and it was at that time Eve Kerr was our founding director, and currently leads the division General Internal Medicine. And there had been some work already prior to me joining MProve around the reduction of unnecessary tests and treatments before surgery. And in particular, had focused on the avoidance of EKGs or heart tracings prior to cataract surgery. Lots of literature supporting that those are unnecessary. And around that time in 2019, we began, I think folks in the health system knew we were starting to think about this problem, and we started to get emails and stories of patients. Some of them were physicians that were undergoing unnecessary testing, their family members, et cetera. And so we were starting to get a lot of anecdote, but obviously, anecdote doesn't make data. And so we were interested in understanding the extent of over-testing before low-risk surgery. And sort of thinking about where we would get that data was a bit of a challenge because we don't do, measuring appropriateness it can often be challenging to get to. So we were able to look locally at Michigan Medicine and sort of understand what was our rate of EKG use before this low-risk surgery, but we didn't have a great idea of was that good? Was that rate good or not? And so we turned to the collaboratives, and specifically the Michigan Value Collaborative, which is a collaborative that's based on claims data. And so one of our NCSP fellows, Nick Berlin, who's now a plastic surgeon at the Brigham and Women's Hospital, he explored the variation in the use of preoperative testing across all the Michigan hospitals. And what we found was that preoperative testing rates ranged from about 8% to 88%. And so not driven by the patient characteristics, but really driven by variation in practice. And where did Michigan Medicine land in that? We were in the top quartile of overusers. So again, going back to, or validating the anecdotes we were beginning to hear. And so our next step was to pivot from the collaborative back to Michigan Medicine and test locally some behavioral interventions that we were able to package and deploy in our preoperative clinics, targeting several of these low-risk procedures. And we were able to successfully take our unnecessary preoperative testing rate from about 66% in that original MBC paper to currently it's around 19%. And so it probably shouldn't be zero when we think about the implementation, low value care. There's always room for clinical judgment, but for the last several years, kind of that floor of around 15 to 20%. We wanted, though, to test that intervention not just at Michigan Medicine, but broadly across the state. So that's where we pivoted back to the collaboratives and were able to get a large grant funded by Agency for Health Research and Quality, which we're now we're just finishing our second year of that grant, which is now testing the intervention that was developed and pilot tested here locally across 16 hospitals across the state using a step wedge design. The first aim of the grant was to roll out that intervention at 3 hospitals, and boy, did we learn a lot, right? Talk about, pragmatic, very pragmatic, in terms of, you have your best intentions and then you have what is realistic in hospitals. And for example, one of the forces that we're seeing in many hospitals that has impacted our both impacted a number of sites that we've enrolled is the tremendous amount of mergers and acquisitions that are going on across the state, right? So we had enrolled, for example, Sparrow Hospital, and all of a sudden they were purchased by U of M. And, you can tell where quality improvement went on their list of priorities, right? Like they're trying to figure out who they work for and getting new badges and things like that. And reducing unnecessary testing was not necessarily at the top of their priority list. We enrolled smaller hospitals that relied very heavily on temporary workers, right? Locum surgeons that were just there as, ships in the night. And so when we think about strategies such as education, well, if every 3 months you've got a new surgeon or a new anesthesia provider, that will greatly reduce the effectiveness of that work. Much of the enrollments through the Quality Collaborative, which is supported for a pay for performance or pay for participation incentive, and the hospitals are very motivated or not to enroll in this work based on sort of the timing of those things. And so we've learned a lot about doing, trial work, implementation work, recruiting, and I think also recruiting to trials that are asking hospitals to do less is also an interesting, we heard in the last talk lots of alerts and triggers to do more testing, right? The ultrasound, it needs to be done every 6 months. And you can make the case to the health system that those types of interventions will pay for themselves. What if the alert you're trying to do is asking people not to order expensive testing that's going to be reimbursed? How does the health system feel about supporting the work that would do that? So those are just some of the kind of practical lessons that we've learned so far, and hopefully an example of how we've gone health system to collaboratives, health systems to collaboratives, and really used both as a learning lab.
Great. Thanks so much, Leslie. Really helpful to have some concrete examples there. And you also shared some insights about lessons learned, so maybe we can circle back to those in discussion. I think that'll be helpful. Shawna, let's turn it over to you to hear about your experience.
Sure. Nice to see everyone. Thanks so much for coming out today. I am also incredibly fortunate to sort of straddle both of these worlds. So I'm also, I think, the one on stage who might consider themselves, well, other than Devin, the sort of card-carrying implementation scientist, right? So I am the non-clinician, I am the PhD who only knows enough clinically to sort of be dangerous, right? And so, I tend to lead with kind of that scientist lens. And so I am kind of always thinking thinking about the study design, how robust can we be, and also sort of be pragmatic. And oftentimes these guys are the ones that have to kind of talk me off the ledge for sort of what I want to do. But I do want to say, a couple of the really cool things that have happened, kind of in these spaces. I hope, Jeff and Leslie have given you, a good sense of kind of the world that we're working with here, right? Both of these, of course, are at least potential for really incredible research practice partnerships, right? And the opportunity for us to do a number of things in those spaces. So one is, of course, to develop a better body of work around the implementation science questions, right? Which strategies are working, for whom, when, why. Also to develop capacity, right, for kind of building this community of implementation science researchers, which we sort of desperately need. And then, of course, bridging this great gap of sort of quality improvement and research and trying to sort of ideally, both improve care, right, improve patient outcomes, and then also, contribute to the science. While we're sitting here, I think want to acknowledge our Improve team over here, who are the ones that unfortunately have to do all the reading, read all the articles that I send them. We're going to add lists to the list now, and Royos, right? All you guys get excited, right? Lots more things to think about here. But I think, so I've been able to sort of be at the table to help with respect to Improve, right? Thinking about how do we sort of leverage our group to identify where the gaps in care are in the healthcare system? How do we design these kind of pilot studies, right? Or these sets of implementation, strategies to try to address these gaps, hopefully diminish these gaps. And then how do we then hopefully, right? I think Leslie and Jeff have both had great success here, then move that, right, to the next stage. And again, by having this kind of like Improve to CQI pipeline that we have available, it's an incredible opportunity, right, for thinking about, we're able to get some pilot data here at Michigan Medicine, show that something is effective, and then, go do our infamous stepped wedge design, right, with, 25 or 30 more sites across the state. The other thing that's sort of really cool in the CQI space is that, again, I'm going to put my implementation scientist, far too many jargony terms on, is that, what they have essentially built is an implementation purveyor organization, right, that is statewide and that has access to, right, all, Michelle's going to talk about OBI in just a minute, but, it's one of the ones where my understanding is they're required, right, to sort of participate in this CQI. So it brings together the whole population, right, of providers across the state that are in this space. So huge potential for impact, right? And on top of that, they have, again, built this infrastructure both for delivering implementation strategies. Primarily, right, we almost always start with this pay for performance strategy, right, which may or may not be effective depending on what you're looking at. But then on top of that, they've also built a very robust data infrastructure, which again, for those of you that are in this space, know how incredible of a resource that is when you're talking about 35 or 40 different healthcare systems, right? You can suddenly move beyond a single EHR, and they actually also, provide some resources for things like clinical data abstraction, right? So you can get some more detailed information for some of those things that, that we were just talking about, right? These kind of like rationale for why things maybe aren't occurring. Because as we always tell our PhD students, right, the EHR is designed for billing, right? It's not designed for research. So with that in mind, right, I think one of the other great things about CQIs is that it allows us to have a set of potential sites, right, that we can potentially recruit for these great studies, and have been a really fantastic place for doing things like clustered optimization trials. So Dana Tellem is not here today, but I am a member of her team for let's see if I can get the whole study design description correct. It is a clustered, non-responder, sequential, multiple assignment randomized trial, right? And essentially what that means, right, is they rolled out pay for performance, and this was specifically for a surgical collaborative that was trying to implement new procedures for like patient level optimization prior to hernia surgery, right? And they rolled out pay for performance for this, and then they looked to see how effective was that, right? Like how effective was that in getting these sites to use, this kind of new resource that was available? And for those sites where it wasn't available, right, this was kind of how many sites we had available in this particular CQI, we then included them in a sequential multiple assignment randomized trial to try to figure out what do we do next, right? What sort of sequence of kind of introducing more intensive, more expensive implementation strategies. And so, those opportunities are just really incredible to have. And again, having that data infrastructure and also that sort of platform, right, for being able to provide implementation support, rigorously, right, across a sort of statewide set of hospitals. I think I'll stop there because that was a lot, but happy to hand it over to Michelle to talk more.
Great. Yeah, please, Michelle, go ahead.
Yeah, well, thank you so much, everyone, for being here and giving us the opportunity to talk about what we love doing every day. It's really a privilege to have this time with you. I feel like I should start by disclosing I have this inconvenient belief that quality improvement should be informed by evidence and should create evidence. And that's really permeated a lot of the work that we've done. So, as Jeff mentioned, I direct the Obstetrics Initiative, or OBI. It's a quality collaborative focused on childbirth care quality. And we're kind of a baby CQI. We started in 2019. So we're in a different part of our kind of life course than some of the more mature CQIs. And we started in an unusual way with kind of a mandate from Blue Cross Blue Shield of Michigan and the employers in the state of Michigan to bring down the cesarean rate in the state. And many CQIs start by identifying some clinical leaders, and they sort of, identify what are the priority areas in our clinical area. No obstetrician would have started with the cesarean rate. Like, it's an impossible problem to solve. Cesareans are clinically indicated, yet overutilized. We have no way to measure which ones are inappropriate. We can't put it on a P4P scorecard because we don't want to create a perverse incentive to not do a surgery that needs to be done. So really, really difficult problem. And we really had to figure out a way to use our outreach strategies from our coordinating center. So how do we get really savvy about audit and feedback, telling stories with data, influencing people's behavior with data? How do our outreach coordinators reach out to hospitals? What does that look like? How much can we do virtually? What are the things that really need to trigger in-person outreach and faculty involvement instead of staff? So we've played in that space really observationally, kind of making decisions and improvements year over year for a while. And then I had the privilege of hanging out with Shawna, who keeps me out of trouble when I pretend to do implementation science. We were able to do, as just kind of our first step to bringing research into our collaborative, a non-responder trial. So in a separate initiative, we felt like we really needed an early win. We're going to work on opioid stewardship. Well, we're doing this really hard thing. We're going to do something that's like a one-time decision by one person. And we're able to do a non-responder trial where we, similar to what Shawna described with Dana's study, sites that were doing really well with pain management after childbirth, we kind of left them alone. There's no reason to augment what we're providing to them. But for sites that hadn't achieved really high levels of adherence to clinical practice guidelines, those sites were eligible for randomization, and half of them continued as is with our usual care, QI support, and half of them got access to one of our staff who would do virtual calls and support them implementing facilitation as our core strategy. And we're still analyzing that, but it looks like facilitation really helped augment the speed of adoption of those practice guidelines and kind of the adherence level attained. So that was our first step. And we're now, based on what we've learned in the opioid stewardship work and in our cesarean work, we are preparing to launch our next initiative in a SMART framework. So many of you may know or have experienced induction of labor, and that's a process to start labor before it begins on its own. And about a third of births in this country are now preceded by induction, and they are managed in highly variable ways. And so we are working to increase use of evidence-based techniques to manage induction. Leslie kind of described a range of practice utilization from 8 to 88%. That is exactly what we see when we look at the caterpillar plot is is wide. And so that's what we're working to standardize. And so in that smart design, we'll give all of our hospitals access to the usual stuff. We have a toolkit online. We show you your data. There's an on-demand dashboard, all the kind of usual things. And hospitals will then be randomized to receive this virtual support. And one of our amazing facilitators, Carrie Simpson, is here. And like, if you're Carrie, one FTE can support 28 hospitals in outreach. So that's a pretty efficient model for us. So we're randomizing all of our sites to that. We'll see who does well. Then performance comes into play. If you are a top performer, we just keep you as you are. But if not, we randomize you to augment up to the next thing, which is in-person site visits. Because one of the things we've learned is our local QI champions are only capable of so much. Sometimes there are local barriers they just are not able to solve on their own, or the champion team has kind of been voluntold and they aren't really the most effective leaders. And so coming in person is another strategy for us to kind of deploy facilitation directly to bedside clinicians as a strategy for driving that quality improvement process forward. So happy to talk about those trials, if that's helpful. And I also just wanted to kind of crystallize something that you've heard from all of us, which is the data, right? What gets measured gets done. So in OBI's registry, we have about 160,000 births that are hand abstracted from all the EMRs. Each birth has about 350 variables on it. So lots of rich kind of data for secondary data analysis to inform the work we do, but also to evaluate outcomes. So in these trial designs, there's no money spent from the research side on data collection or recruitment of hospitals, because it's all kind of embedded in the collaborative infrastructure already.
Great, thanks so much. Super helpful summaries from each of you. I'll get us started maybe with a couple of questions and then happy to open it up for a broader discussion. I wanted to start with a slightly more practical question. You mentioned, Michelle, sort of, I don't know, pretending to do implementation science, but in fact you all do very rigorous implementation research or de-implementation research. And I was curious if you could share some insights, particularly from the clinician scientists, about how you came to doing implementation research and how your work with MPROVE and or the CQIs with these organizations have facilitated that.
I could start. I built in some training in my K award. So I think that's a nice time to get some training. There was an NIH program at the time called TIDER. So I was able to attend kind of intensive learning around implementation science in that way. And then our amazing Department of Learning and Health Sciences has incredible courses that you can take here. So that's been another great way for people to learn, and lots of work in progress kind of opportunities to really take what you're learning in a didactic space, start applying that. I think going to national conferences has been really helpful, the Academy of Health D&I conference. And I think just recognizing this field is constantly evolving. So Dr. Smith, shared some of the new tools that we're all now embedding into our work, the implementation research logic model and lists. And so it's not a static field. It's not a kind of one and done learning situation, if anything is.
I might add to that. Similarly, I got started in implementation science on a K. Ann Sales was my mentor. She sort of helped guide me. But I think about my role as an implementation scientist very much as I think of my role as a clinician. Right? And so in the clinical space, I will always have more expertise than many and less expertise than some in whatever my domain is. So I'm a cardiologist. I'm going to have more cardiac expertise than a primary care doctor or a hospitalist. But I'm going to have less expertise about how to actually do or when to do a cardiac cath than an interventional cardiologist who's gone on and done more than me, right? So my role in the clinical world is very much defined by who are the people around me I support and who support me. And I think of my role doing implementation science work as being very much the same, right? Like I know a lot of the language and I can kind of talk the talk, but I will never have the card, so to speak, that others will. And so I want to work with them. And so that's why I don't write grants alone. I write grants with Shawna, right? Also, I think from an institutional standpoint, that's why we create some of these infrastructures. So that's why MPROVE exists, because the staff can bring a lot of that. That's why the Department of Learning Health Sciences exists, because there's a lot of people who are expert who can then come in and help. That's why Misher has the D&I incubator and the other resources. And so I really see the way that I engage is I can bring a certain level of clinical expertise and an ability to talk and understand, but I'm going to have to partner with somebody who knows it even more deeply than I, and people who can execute it on a day-to-day basis. And that sort of matrix comes together to really achieve our goals.
Did you want to add anything, Leslie, or similar?
Very similar path. A similar program that I participated in. Again, Anne was a mentor, and there was a program at WashU specific for cancer researchers, similar to CIDR. It was very helpful. The only thing I'll add is I also learned a lot from my summary statements. So every time I submitted a grant, think about it. The grant's being reviewed by implementation science experts, and they would, point out things I didn't include or suggest things. And I would really use those summary statements as a point to learn. I would go and really dig into the literature on that particular thing. Because as Michelle mentioned, it was really an evolving field. The language was evolving, the frameworks were evolving, the techniques were evolving. And so it was a way to keep up with sort of where the thoughts at the study section were also going, is really taking those summary statements to heart.
Great. Thanks so much. I'd like to ask one other question before we open it up, thinking about our other theme for the symposium today. In your experience working with MPROVE and the CQIs, to what extent do these groups, organizations represent learning health systems or contain elements of the learning health system, and what might be some opportunities for growth moving towards a learning health system within MPROVE, within the CQIs, and thinking more broadly about lessons from those groups that might translate to Michigan medicine?
I might start, and I'm going to echo a lot of what we heard in the two keynotes. Speaking about MPROVE specifically, when MPROVE gets involved in a project, we spend a lot of time thinking about, is the problem real? Is it measurable? Is it something that can, have impact on? And so there's often this sort of seeming delay before we really get going. And many projects that we start on 3-4 months later, we decide it's not there. There's not enough. There's not the practical nature of it. But there's two projects I'm going to maybe mention that kind of fit in this. And the first was a clinician in the emergency department came to us and said, hey, I saw that there's this new guideline that came out, institutional guideline, saying that patients with the pulmonary embolism, so that blood clot in the lung that you heard about earlier, that we're not supposed to admit all of them to the hospital, that some of them can be safely sent home. But I'm an ER doc, we admit all of them. Is that really the case? And so we had to go to the data to look, right? So we spent the time understanding what does it look like, what's happening, and sure enough, we're only discharging 5%. Well, what's the potential? It's probably 40 to 50%. So there was a huge gap there. And then we had to understand, well, why is that happening, and doing all of the work, right? So following through the implementation process and then figuring out, how are you going to solve this? And as was mentioned, no problem in healthcare is solved without an EHR alert these days. But an EHR alert is never sufficient to solve a healthcare problem. So we had to come up with the whole package, right? The whole thing that came together. And from that learning cycle, what we realized is if you put the alert at the time an ER doc goes to enter the admission order, they're just going to get upset because they've already anchored on that decision to admit. And it took a lot of time sitting there watching what was happening, talking to the frontline clinicians to realize that docs start thinking about disposition before they've ever met the patient, which means we have to go all the way back there to get that sort of nudge in their brain to say, wait, what are we going to do? So what we built was an alert that happened at the time they order the CT scan without even knowing if it's going to be positive. And we have to calculate what the risk scores are and then pop it up appropriately. And then we can put them in the right framework to change. And that had to come with 4 or 5 other components, which were the things the docs said they needed, in addition to what we realized that they needed. And now we've gotten our discharge rate up to about 40%. And so we sort of learned from the data what we needed to do. In a very different way, from another project we worked on, you heard about spironolactone, that drug that can help to prevent people from dying and readmission and all of that. Well, we said the same thing, but we said, can we do this in the hospital? Patients admitted with heart failure, they're not being prescribed spironolactone even though they should. Can we use an alert appropriately timed, targeting specifically the residents? Because we know attendings don't enter orders, right? Only residents do. Can we add a gamification? Can we get them to sort of figure out which team is going to do best? Like all these different strategies and put it out there, and it made almost no impact. And so we had to sort of look at our learning and say, how do we adjust? And the answer was we actually needed some clinical care navigators. We had a completely different strategy to come in and say, okay, here's how we can make the change. And so by trying, learning, looking at the data, understanding what does and doesn't work, and then changing the strategy, we were able to really get to our end goal. So I think that's hopefully 2 examples of how we're trying to use implementation strategies, but in a learning health system model.
Great. Thanks so much for those examples.
Yeah, I'll add just a couple more on top of that. I would say one that I think MProve has grown rapidly since Jeff and Leslie both took over as directors, in part because we've had some great success in transferring projects sort of from the pilot phase at Michigan into federally funded NIH larger scale projects. But one thing that we've really been trying to do recently, and I should, Tony's over there can correct me if I get any of this wrong, but is also trying to build the capacity for doing and being interested in implementation work or sort of learning, right, work, quality improvement work among clinicians system-wide, right? We need the eyes on the ground to help us to get us that first data point that says, hey, we think there's a gap here, right? I saw these new guidelines that came out. I don't think anybody here is doing that. And so we're now creating some mechanisms for them to kind of say, hey, I think this is really interesting. They oftentimes, of course, don't have the capacity to go look at the data and see if that gap is real. And so part of, I think, where we fit into the system is for them to bring that question to us. We do some of that legwork, and then we see, whether or not that's something that we should try to address, right? Of course, that's when things get really complicated. You have to get the stakeholders involved, all of that. But I think that's been a really cool and exciting place where MProve is sort of moving. And again, in sort of the pursuit of this bigger learning health system idea. And the other thing, and I love seeing Michelle, and Michelle is such a fantastic leader for OBI. One of my, if you hear students that take my classes, one of my biggest soapboxes about implementation science is that we tend to think about things in a vacuum, right? It's like, we're going to solve this implementation problem. And I think, people like Michelle who have this implementation science lens, but also have a view, right, for kind of like, what are all of the problems that this field is facing? And to what extent are the mechanisms that we're using with these strategies to address this problem that we're finding evidence of effectiveness for transferable, right, over to this? And then we can make decisions as to, do we need another randomized control trial? Or do we feel like we have enough knowledge already that we can just try to solve the problem and make the case for expending more resources, or et cetera? So I think, in both of those spaces, I think there's good potential there, and I think we're moving in the right direction.
Great. Thanks so much for those reflections. Happy to open it up if folks in the audience have questions, or if there are questions coming in online. I can also keep asking questions. One other, maybe I think Nora's looking online, but kind of wearing my grant writer's hat, another sort of more practical question is about kind of walking the line between thinking about the CQIs in particular, like the unique features of the CQIs that make them, in some cases, really well-suited environments for implementation research, potentially federally funded implementation research, and kind of balancing that with potential concerns about generalizability, especially thinking about like financial incentives and that sort of thing that might be difficult to implement in other settings. Just curious how you all think about that when you're putting together proposals that leverage these organizations.
Yeah, I can comment on that because that has very specifically been called out in summary statements. reviewers will comment that anything that comes from Michigan is not generalizable, specifically because of our quality collaboratives and our incentives. Some of the arguments that we have, made and subsequently been at least successful in getting funding, whether or not those individual arguments landed, is that, making sure that, nothing would prevent any other state from establishing collaboratives, and in fact, many do. At least I'm not as familiar with sort of outside of surgery, but there are about 20 states across the U.S. that have some form of surgical quality collaborative. Certainly Indiana, Illinois, many neighboring states, many are payer funded as well, some are not. But, so we can make a little bit of the generalizability argument, and that many states do now have collaboratives. And then making sure, I think that's where you make the argument that you're going to be really good at your implementation guide, exactly what you did, how you did it, so that other people can use it. I think those are a couple of the strategies we've used.
I also think there's two ways to potentially respond to it. Number one is, if you think the pay for performance element is a key strategy, then call that out as potential policy implications of your research, right? Because that then may inform what CMS and others would choose to do. Also, the CQIs exist as a collaborative of people together with a lot of data. That doesn't mean that the projects being done have to be ones that are a part of the pay for performance metrics. So as an example, we did this low risk PE project. We piloted it here at Michigan Medicine. We then got R01 funding to roll that out across the state through one of the other CQIs called the Medic Collaborative. That is not a part of their quality metrics. So they are not being scored on that. They are not getting payment based on what % of patients are discharged or not. But we're able to leverage their data infrastructure to say none of these sites have to collect additional data for us to know whether or not this has been effective. So you can sort of run something that's kind of sitting adjacent to a CQI and leverages the data without necessarily having the pay for performance element be a part of it. So I think it's really important to clarify, what are the strategies you're proposing? What of those exist within the collaborative or not, and be explicit about that.
I think also just we have a kind of a similar problem. We have perinatal quality collaboratives in every state, but they don't have P4P. They don't have data collection like we have. So trying to think really intentionally about when we use P4P. And P4P is not like magic, right? It's not 100% effective in every context. It is often a really blunt tool. And so we are, in our SMART that I described to y'all, we're using P4P to reward people for attending things, right? Essentially for participation. We very explicitly have not put a financial incentive on adherence to evidence-based behaviors, because if we do that, we know the findings are now not generalizable, and we are interested in generating an intervention that works in the real world with the kind of common constraints many hospitals face. So that lets us then, if our intervention is found to be effective, hospitals can do whatever they need to do to get people in chairs. If they're in the chairs, they should have the same effect that we see in our trial, right? So being really thoughtful about when you do and don't turn on that incentive, because it is part of your intervention now. It affects external validity, and being thoughtful about, what that incentive can really do. So is it maybe not going to be enough to drive improvement? Maybe it will help us with maintenance, 2 or 3 years down the line, but really being thoughtful about when we do and don't turn on that intervention.
That's helpful. Shawna?
Yeah, I was just going to comment on the back of that. Pedro Klush is in the audience, so I'll give him a head tip for the sort of mechanistic turn in implementation science over the last few years. And I think that, that stuff becomes really important when we're doing this kind of work. We're talking about the extent to which we're choosing strategies to address specific barriers, right? All of our logic models, right? And the extent to which that should be generalizable, right? Even given that we have this sort of infrastructure, right? So given those inputs, we should still expect to see similar results. I told Christian earlier I was going to give him a hat tip too. Christian Stensland in the background has been doing some really great work thinking about kind of work that's being done across the different CQIs, right? We love this idea of kind of like what's happening, before you get to like the recruitment stage and kind of winnowing out sites. And what does that tell us about sort of equity in these spaces, about sort of interest, about capacity for doing implementation work. And again, all of that stuff is incredibly important for generalizability and for understanding the implications of the work that we're doing. And again, I think we just have such a great resource here for exploring that in a relatively robust way.
That's great. Those are really helpful thoughts. Thanks for sharing. One other question I have, I guess a little bit bigger picture question, is around how leaders in learning health systems can support alignment between different incentives that affect providers and investigators, namely like the imperative to improve patient care and incentives to obtain federal funding, and how to sort of facilitate alignment there based on your experience working with these groups. Any thoughts about that?
I think that's a big challenge.
Yeah.
One of the things, so I'm going to pull back the curtain a little bit, at our CQI leadership meetings, one of the things we talk about a lot is how do you get engagement and prioritization at all of your sites for the thing that you're working on. And to do the work often requires people who are committed to say, I'm going to go through that quality improvement process. And so often what happens is people look to their quality departments to say, hey, I need help solving this problem. And so one of the things we've been thinking a lot about is how do you select the problems and the projects that align both with what we as the clinicians in the collaborative think are really important, but also align with what the health system C-suite see as really important. And so are there reportable metrics? Are there financial ties? Are there things that are being externally driven that we can align to? And so I may be really interested in the appropriate prescribing of a specific drug, but if that's not being measured by CMS, by Leapfrog, by Joint Commission, by name any of the organizations you want, it may be harder to then get alignment from the C-suite to say, we're going to throw resources into that. And so can we identify different ways to say, well, this is really going to affect readmission. Okay, now I've got sort of a different ear. Is this going to impact sepsis or length of stay or any of those other things? So thinking about the way you tell the story and picking the projects that align both with what you have clinical interest in, but also what you're going to be able to get the sort of the ear of the leaders is important. And then when you can say that's measurable, doable, and everything that's rigorous enough to get funding, that's kind of the perfect trifecta to move forward, which means a lot of projects you're just not going to be able to do now in this particular space. They're not bad, they're just not now.
That makes sense.
I'll make a comment that I think never let a crisis go to waste, is that I sense that decreasing hospital margins is going to increase the scrutiny on quality improvement work. And I'll give you an example. So I'm a surgical oncologist. I'm involved at the national level with the Commission on Cancer, which is the largest accrediting body of cancer centers in the U.S. It accredits approximately 1,400 hospitals, which serve about 70% of cancer patients in the United States. The COC, at the direction of very well-meaning clinicians, develops quality measures and then requires those, attaining those quality measures for accreditation. Those quality measures are not often rigorously thought about, designed, or evaluated. And hospitals are putting increasing scrutiny on, well, why do we need to be COC accredited? Why do I need to pay a registrar? Why do I need to support the salary of a cancer liaison physician? Why do I need to support a Commission on Cancer committee in our cancer center? What is the return on investment for our hospital or in our health system for this expense? And so I think for these quality improvement bodies, it's going to be incumbent on them to demonstrate that they have the right quality measures, that the strategies that they're recommending are effective, and that those quality measures lead to downstream improvement in patient outcomes. And I think so. I think actually that there's greater scrutiny on how much money is being spent on quality improvement, data collection, and whatnot, and therefore there's going to be more, scrutiny on the rigor of that work. And I think that actually works to the benefit of those of us who believe quality improvement should be evidence-based.
Really great point. Thank you. Any other questions or questions coming in? Okay.
So a few questions from the online chat. I'll start with one of them. Someone asked, I wonder in the CQIs, are there people with lived expertise as part of each of these to ensure the perspective of real patients help drives what matters and keeps the overarching why critical for positive change for other patients?
I can speak quickly to that. We have a patient and community action board that serves as a committee, just like our executive board. So our executive board comprises members of our hospitals, the major health systems. They help us select initiatives and decide on our P4P incentives. And there's other incentives we have in the program as well. So our patient community action board has veto power. They have decision-making capacity about what we work on. They come to our meetings, they ask questions, they change the dialogue in the room just by being present. They're a really powerful force, and they absolutely bring a different type of expertise than what we have as clinicians or researchers. And we've seated that committee on our other committees. So the committee that decides, the data measures that go in our data collection manual, et cetera. We have patient voices in those spaces. We have also launched a statewide survey. So patients across the state are being asked about their experience of maternity care. So that's a really important way for us to say, we sometimes forget this, but patient-centeredness is a critical element of healthcare quality. And if we don't measure that, if we have no outcome in that space, it's hard to focus people's attention on optimizing that. So it's taken quite a few years to just build that infrastructure for statewide survey collection, but we're really excited. We're getting to the point where now we can actually use those data and embed them into our quality initiatives.
That's excellent. Thanks.
Another online question. This is directed at Dr. Dossett. How do you explain the LHS paying for itself when it comes to the de-implementation work that MPROVE leads?
That's a really good question. A few places where we have been able to successfully make this argument. Michigan medicine is incredibly capacity constrained in inpatient beds, ED beds, staff, et cetera. So for example, at the time we began this work to reduce unnecessary preoperative testing, we were unable to promptly get stat labs in the ICU, right? Because so if we're having phlebotomists spend their time in the outpatient setting drawing labs that are neither going to change patient management or prevent adverse events, and then they don't then have the capacity to go draw the labs that really matter, that's an argument that we can take to the health system leaders. And in a similar way, MPROVE is being commissioned to think about reducing unnecessary imaging, and you think, well, why in the world would that happen? Why would Michigan medicine want to do fewer radiology exams? Well, because if any of you have attempted to get an advanced imaging exam in our health system, or I saw a patient this week that, I saw you got your MRI at 2 a.m. on Saturday, right? Because that is the extent at which our system is stressed. And when we can't get access for the the exams that really are needed, for example, before a patient can go to surgery, or are needed before a treatment plan can be initiated, because we're doing a lot of things that are unnecessary. That improves quality and value in our health system, and is an argument that resonates with our health system leadership. And just a couple examples there.
I'll add one other very quickly. When you free people up from work they used to do, they can then do other work. So James Henderson, who's part of the MPROVE group, built a model that better was able to predict whether people needed to have surgery at the main hospital or could have it safely at an off-site ambulatory surgical center, which is not only lower cost to the system, but if we can more rapidly do that, we don't have to have manual review of those charts. Those physician assistants can now do other things like actually care for patients in an OR. We can get the OR scheduled sooner. So it's a win for the system, it's a win for the patients, it's a win for the healthcare providers. So that's many of the arguments that we try to make.
Okay, another online question. This was directed to Dr. Barnes. Given the question that was asked in Dr. Horowitz's keynote, what strategies has Michigan employed towards becoming a learning health system that have worked and haven't worked?
So that's a big question, and we're already over time, so I'm going to try and be very brief about it. I think we try to learn from our data, and we try to empower people with the skills to say, how are we going to implement things in a smart way, in a way that's actually going to improve care, improve the experience of patients, improve the experience of clinicians, reduce burden. Those are the goals, and we have several successes, and we can sort of tick them off. I think the challenges, the places where we still need to grow and improve, is we need to have greater access to data. More importantly, we need to have greater access to people who know how to do that process. So if you sit on the committee that reviews all of the alerts that come up, you are being bombarded by so many requests, you've just got to get it built and move on to the next one. And you don't have the time to step back and say, has somebody really done a user-centered design process? Do they really know what this is going to look like? Have they thought about the implications of when this is going to fire, whether the clinician is actually in the right mindset to know what to do, right? We are so busy trying to just get them done. We don't have the capacity to step back, let alone the capacity to build, to then analyze, to then go through all of that. So I think there's opportunity for us to continue investing in that piece, which will deliver better care, better quality, better experiences for everyone. So that's where hopefully there's some more room to continue growing. We've had some successes. That story is important. We hear about the external ones that give us a model for where we want to be. And so we'll continue moving down that journey.
And I'm assuming you're good. Am I good?
Yep.
All right. Wonderful panel. This is a really great discussion. And I sort of have a big picture question collectively about the CQIs and MPROVE, about how they really could be an opportunity to be sort of a meta learning health system or system. So the question is this. So, one I think the key strengths is the work with the academic affiliate, University of Michigan and other universities. Universities create innovations. They get, the science happens, but also some of the best ideas for the science happen with your key stakeholders, your patients and families, your frontline providers in these places. And I'm wondering, are there opportunities or mechanisms by which innovations in making practice better, or even just innovations in treatments, are surfaced or identified by the different places across the state of Michigan in these collaboratives? And are there opportunities for frontline providers to get involved in getting these innovations maybe further tested, maybe speeding up that translation cycle so we can get things not incrementally done in 5 randomized controlled trials over 80 years, but maybe something that's like pragmatic, where people can maybe test these innovations and then work with an implementation scientist to maybe further scale them up. So just thinking that way.
I'll speak to that. Friday is one of our quarterly Michigan Surgical Quality Collaborative meetings. We're having a panel to talk about our quality metrics and how we've done at achieving those across the state. And the panelists are 3 surgeons from very small community hospitals that's who I want to hear from, right? I want to hear from the N of 1 surgeon who at, some small hospital on the west side of the state managed to take the outpatient mastectomy rate from 10% to 90%, right? That's who I want to hear from. And so we do try to, engage those frontline providers with these lived experiences in the real world setting. I think the challenge to get to what you are articulating is that, and I think the AMC faculty of the CQIs could do a better job of mentoring and educating those frontline clinicians who don't have haven't had K awards, don't have the time to sit in a seminar like this. How can the CQIs train up some of these clinicians to do that frontline work? I think is an opportunity.
Great. Thanks so much, Leslie, and thanks to all of you. Really helpful insights. I appreciate your time. Thanks.